Hi everyone. Until yesterday, we have discussed up to the approaches for treating antihypertensive drug. So this is the slide what we discussed up to yesterday. So here, how the antihypertensive drugs acts will discussed. So one, they acts by four mechanisms. One, either by dilating the blood vessels, or by decreasing the fluid volume, or by inhibiting the RAS system, or by blocking the sympathetic system. Okay, so these are the four mechanisms for antihypertensive drugs. Okay, so what are the drugs that acts by dilating the blood vessels? Direct vasodilators, at the same time the calcium channel blockers. So whereas which drugs can decreases the fluid volume? Diuretics can decreases the fluid volume. And what are the RAS inhibitors? So one is the renin inhibitor, and another one are the ACE inhibitors, and another one are the angiotensin receptor blockers. So what are sympathetic blockers? So these are alpha blockers, beta blockers, alpha and beta blockers, and central sympatholytics. So this is what we discussed until yesterday. Okay. So in the next slide, we'll discuss about the classification and examples for the various antihypertensive drugs. So you can see, so here diuretics include three classes: thiazides, high ceiling, and potassium sparing diuretics. Here thiazide diuretics examples are, we'll discuss while discussing individual drugs, we'll discuss all these points. So which includes the diuretics and direct renin inhibitors, and which includes angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and also sympathetic inhibitors, in that beta blockers, alpha and beta blockers, alpha adrenergic blockers, and central sympatholytics. So whereas in calcium channel blockers, so again there are three categories. So one is phenylalkylamine, and then another one is benzodiazepines, and another one is the dihydropyridines. Okay, so under vasodilators, again the arteriolar dilators and arteriolar and venodilators. So this is regarding the classification of antihypertensive drugs. So while discussing individual drugs, we'll discuss the examples. Okay, so here first category of antihypertensive drugs are the diuretics. So there are three different groups of diuretics we can use for the hypertension. So what are those? So thiazide diuretics, high ceiling diuretics, and aldosterone antagonist. So what are thiazide diuretics? What are the examples for the thiazide diuretics? Hydrochlorothiazide, chlorthalidone, indapamide. These three are used as a antihypertensive. So in the high ceiling diuretics, we can use furosemide and bumetanide. So in case of aldosterone antagonist, so spironolactone and eplerenone we can use. Okay. We'll see. So how the diuretics acts. So here the diuretics acts by decreasing the reabsorption of the sodium and water at various levels of the renal tubule. Okay, so here either they acts by inhibiting the carbonic anhydrase enzyme, either they acts at the thick ascending limb of loop of Henle by inhibiting the sodium potassium 2 chlorides importer, or it acts on the distal convoluted tubule or cortical diluting tubule. So where it acts by inhibiting the sodium plus chlorides importer. So and also it acts at the collecting ducts. So where either they are the aldosterone antagonist, either they are acts by blocking the sodium channels. So here this whatever the drugs, those are acting acts at the thick ascending limb of loop of Henle are responsible for the 25% of the water reabsorption. So that's why these drugs are considered to be the high ceiling diuretics. So here remaining 5% of the water reabsorption, water and sodium reabsorption is takes place in the distal convoluted tubule. So that's why thiazides are considered as the moderate diuretics. So whereas, so here until the tubular fluid reaching here, collecting ducts, most of the water and sodium is reabsorbed. So whatever the aldosterone antagonist and potassium sparing diuretics, so they here they are less, they cause less natriuresis. Only they decreases the fluid volume by 1 to 2%. That's it. Okay. So they are considered as the less efficacious diuretics. But why we use this? So in order to, in all cases there is a hypokalemia here. So these drugs can cause hypokalemia and these drugs also can cause hyperkalemia. So but in case of the drugs acting here, so those are what? Aldosterone antagonist and sodium and sodium channel blockers. So these can decreases the potassium secretion into the lumen of the renal tubule. So thereby it decreases the sodium potassium excretion. So that they spare the potassium. So that's why they are used as an adjuvant drugs along with the thiazide diuretics and high ceiling diuretics. Okay, so in the next slide we'll discuss with individual drugs and mechanisms. So here thiazide diuretics. So here the thiazide diuretics are considered as the standard first line antihypertensives. So here they are used for uncomplicated hypertension, and they are effective in the elderly patient, and they are effective for the systolic hypertension. So why they are effective for systolic hypertension we'll discuss in the further classes. And they are the mild antihypertensives, and average fall in BP is 10 mm of Hg. It won't be decreased beyond the 10 mm of Hg, and they potentiates the uh, and all other antihypertensive drugs except the dihydropyridines. Why? So here dihydropyridines also cause fluid retention, RAS activation, and whereas diuretics, which causes the RAS activation. So that's why uh, the diuretic effect of the thiazides is nullified. So that's why should not be used in combination with dihydropyridines. So here most of them are long acting, and they are cheap, and they do not cause CNS side effects like central sympatholytics, and they do not cause postural hypotension. So these are the some advantages for the thiazide diuretics. So once because of long acting, once daily dose is sufficient. So and they are cheap as well. So that's why they are considered as the first line antihypertensives. And when we used at lower doses, they do not cause whatever the side effects that caused at the diuretic doses. So what the side effects it causes, which causes hypokalemia, which cause hyponatremia, and it cause hypomagnesemia, hypocalcemia, and which cause glucose intolerance, and which cause dyslipidemias, and which cause, because of hypokalemia, it cause arrhythmias and all those things. So these are not caused because of the because when we used at our lower doses. So let's discuss the mechanism of action of the diuretics. Here we already discussed. So diuretic can act at the distal convoluted tubule. Okay, here we already discussed, right? So where they act at the distal convoluted tubule. How they act by inhibiting the sodium and chloride symporter. So when sodium and chloride symporter is inhibited, sodium reabsorption is inhibited. So thereby the water reabsorption osmotically is also reduced. Okay, so which decreases the sodium as well as water reabsorption up to 5 to 15% like that. Okay. Uh, so next slide, here so what they do, they causes the reduction in fluid volume up to 10 to 15%. So initially the fall in BP is due to reduced cardiac output. So how they reduces the cardiac output? So when the fluid volume is reduced, ultimately the venous return to the heart is reduced. So once the venous return to the heart is reduced, nothing but amount filled in the heart is reduced. So nothing but the cardiac output is also reduced. So but on chronic use, upon long term use, this cardiac output is restored because of reflex sympathetic activity, reflex mechanisms. But the fall in BP is maintained. Fall in BP is maintained because of the decreased in total peripheral resistance. How they reduces the total peripheral resistance? So here, uh, upon long-term use, some extent of cardiac output is restored, but sodium deficiency is maintained up to 5%. Okay, small extent of sodium deficiency is maintained. So this sodium deficiency in smooth muscle cells may decreases the vascular stiffness. So their vascular stiffness is decreased nothing but it may uh, d- I mean constriction is reduced. So thereby it reduces the total peripheral resistance. On short term use, it acts by reducing the cardiac output. So majorly it acts by reducing the cardiac output. That's why those are effective in the isolated systolic hypertension, because cardiac output is responsible for systolic hypertension. So when the cardiac output is more will be the systolic hypertension. Okay, so then another drug here, two major drugs we used as two major thiazide diuretics we used for hypertension is chlorothiazide and hydrochlorothiazide. So recently another drug is also introduced, that is indapamide. So it is a moderate efficacy antihypertensive, but it is effective at the lower doses. Okay, so additionally along with the fluid deficiency, which also causes the vascular smooth muscle relaxation. So because of this, at lower doses only it lowers the BP. Okay, so the dose required for the hypertension treatment is very less. So that's why it do not cause other metabolic and electrolyte imbalance as like other diuretics. So this is the advantage for the indapamide. Okay, so then we'll discuss another diuretic, that is loop diuretic. So how here loop diuretics, where they act? So here in the first slide only we have seen. So loop diuretics acts at the loop diuretics acts in the thick ascending limb of loop of Henle. So where what they blocks the sodium potassium 2 chlorides importer. So what, so this is responsible for this 25% reabsorption of the sodium. So that's why, so they are considered as the high ceiling diuretics. Okay, but they are high ceiling diuretics, but they are not considered as the, their antihypertensive effect is not as thiazide diuretics. Why? Because so here uh, the fall in BP is entirely depends upon the decreased cardiac output. So here, why they are short acting and they do not maintain the 24 hours, they do not maintain the round the clock sodium deficiency. So that's why they do not uh, reduces the total peripheral resistance. Here the mechanism of action is only because of decreased cardiac output, but because of high efficacy, so they causes bulk diuresis. Because of this, which causes the electrolyte imbalances. So that's why these are not indicated for the mild hypertension crisis. So they are only indicated for the complicated hypertension, which is due to renal failure or which is due to congestive heart failure. So in these complicated conditions only it is helpful. So another category of diuretics are the aldosterone antagonist. So how the aldosterone antagonist acts? So what are those? Spironolactone and eplerenone. So where they acts at the collecting ducts. Here they acts at the collecting ducts. How the aldosterone antagonist acts? They acts by binding to the aldosterone receptors of the aldosterone receptors in the distal convoluted tubule. So this binding decreases the activation of sodium channels and potassium channels. So that's why the sodium reabsorption is does not take place, and potassium secretion into the lumen is does not take place. So that's why which potassium concentration within the blood is increased, and sodium loss within the urine is increased. But until it reaches the collecting ducts, most of the sodium is reabsorbed. Only 1 to 2% of the sodium is available for the excretion. So that's why they are mild diuretics. That's why they are not they cause mild antihypertensive action. So that's why they are used as an adjuvant drugs with other diuretics such as thiazide diuretics and high ceiling diuretics as to prevent the potassium loss, okay, to prevent the hypokalemia. Okay, so and another effect of aldosterone is, so here aldosterone RAS overactivation, increased aldosterone levels are responsible for the vascular remodeling, which is responsible for hyperplasia, thickening of the blood vessel, and which is responsible for the fibrosis, replacement of the functional unit with the fibrous tissue. So this lost the elasticity of the blood vessel. So this further damages the condition. So that's why this is the another advantages of the aldosterone antagonist. So here eplerenone, so which is preferred over spironolactone, because spironolactone is the steroidal uh, analog, so which causes other steroidal hormone abnormalities, which decreases the progesterone levels, which decreases the testosterone levels. So that's why which causes the hormonal imbalance, which causes loss of libido, and which causes menstrual irregularities, and which can cause other side effects, so other hormonal imbalances. So that's why eplerenone is preferred nowadays. So this is regarding the diuretics. So in the next class we'll continue with the calcium channel blockers.